Good afternoon and good evening. I'm Dr. Shaji Varghese Kudiak from the Philippines, welcoming you all to the 362nd continuous uninterrupted Zoom session of International Forum for Promoting Homeopathy. Before we proceed, I would like to have 1 minute silent prayer for the success of the vision and missions of the IFPH and also for the successful conveyance of the message expected of today's Zoom session. So let us have 1 minute silent prayer. Thank you. So before we proceed, I would like to have a small introduction about IFPH for the sake of those who participate in our Zoom session, which are uninterruptedly taking place for the last 361 days continuously. We are reaching 365 days on August 31, and we are making history in the history of medicine and the history of homeopathy for such a massive, passionate, uninterrupted Zoom session. So, International Forum for Promoting Homeopathy is an organization formed by a group of homeopathy lovers, doctors, in association with the homeopathy students at the time of the pandemic when the world remained unaware about how to manage this pandemic, where homeopathy emerged as the best preventive treatment and rehabilitative solution. But the world leaders, healthcare authorities, and the world at large remain unaware about it. So we started daily Zoom sessions to create awareness about homeopathy and its possibilities and potentials among world leaders, healthcare authorities, and ordinary people at large in different countries, and also to inspire homeopathic doctors and homeopathic organization leaders the need to propagate and promote homeopathy in respective countries and areas. And today we are on the 362nd day, and we are having a very important person as our chief guest, who is none other than Dr. Lipi Pushpa, the Beta, who is a research officer, scientist level 3 for homeopathic drug research of Homeopathic Drug Research Institute under Central Council of Research in Homeopathy, Government of India. Dr. Deveta completed her BHMS degree from Dr. ACH Medical College, Bhubaneswar, and MD degree in Organon and Homeopathic Philosophy from JSPS Homeopathic Medical College and Hospital, Hyderabad. Joined CCRH as a SRF in the year 2006 and then research officer in the year 2009. Major contributions in clinical research and clinical verification. Extensive work done on number 1, homeopathic management of vitiligo. Number 2, homeopathic treatment of acute adeno-lymphadenitis in filariasis. Today, Dr. Lipi Pushpa will be talking on case report of vitiligo treatment by homeopathy. Before I proceed to Dr. Lipi, our Joint Secretary of IFPH has raised a hand, so I go to Dr. Yahya, who is the Joint Secretary of IFPH. Dr. Yahya, please.
Yes, can you hear me? Okay, there is an important announcement because tomorrow, as the 365th day celebrations we are initiating, so the time is already fixed as 10 o'clock. But due to the availability of our chief guest, K. Muralidharan MP, he will be available only by 9:30. So our program will be starting by 9 o'clock. That is an important announcement. So Dr. Shaji Kudiak, please, again, you have to mention in between the same matter. We'll be initiating the program by 9 o'clock.
Okay. So in 9 o'clock, 9 a.m. Indian time. Okay. So we are initiating our 365-day celebrations 2 days earlier from tomorrow. And our one important guest, who is a member of parliament and important political leader, will be available only at 9:30 Indian time morning. So we will be starting our program at 9 a.m. So I request all those who wish to join, please join us at 9 a.m. Indian time. please look into your respective regional times in line with in a respective timing of 9 a.m. Indian time. So now I hand over the platform to Dr. Lipi Pushpa to have her presentation. Dr. Lipi, you can continue. You can take over the platform and start with your presentation.
Thank you. Thank you, Dr. Shaji. Am I audible?
Yes, you are audible.
Thank you very much, Dr. Shaji, for this welcome. And thank you very much to this association, International Forum for Promoting Homeopathy, for giving me the chance to present this paper or present this case report. And most important is I'm congratulating you for this completing this 365 days or 1 year of completion of this continuous daily basis presentations of your forum, of this forum. So congratulations and thank you very much. So today, myself, Dr. Lipi, as they have already introduced me, and I am a CCRH scientist from Central Council for Research in Homeopathy and Scientist 3. And today I'll be speaking of the most common and complicated disease. Is my screen visible?
Yes.
Yeah, yes, visible, yes.
Yeah, today we'll be talking of this. It's very commonly seen in India, but it's very complicated also disease, that is vitiligo. As we all know, every one of us is aware of this particular disease condition, and everyone in his or her clinic might be getting number of cases of this particular clinical condition. It may be, of course, the treatment part is very difficult also, and it's also complicated because of its pathogenesis and etiopathogenesis. We had these complications in treatment part also, but still we have a scope. As far as our path is concerned, or our treatment part is concerned, homeopathy treatment is concerned, we have a scope in this clinical condition of vitiligo. In whatever treatment we are giving, it has a scope apart from the other systems of medicines. We have a good scope in this clinical condition, and I had in my career from this 2009 of 2006. I started a career as a senior research fellow, and then in 2009 I became a research officer. I started my career with this vitiligo. When I joined CCRH, I started with this vitiligo, and till now also I'm continuing with vitiligo. A number of studies have been made, and I am a part of those studies. Every time I have been a part of the study, and since this long many years, I have studied this part, this clinical condition. And I like to present on this clinical condition, which is of course a backward part, and which has a very, it's not a very successful part of our treatment, of our Indian society or treatment part, but still I would like to present a case report on vitiligo showing that which when we are coming to promoting homeopathy, we should learn that such cases are also there where homeopathy also acts, and it has also a very good scope on this, a positive aspect for treatment, positive aspect of treatment in this part of the clinical condition. Okay, so talking about vitiligo, first let us know, everyone is aware what is vitiligo. So it is as we know, it is an acquired, most important acquired. It's an acquired pigmentary anomaly of the skin characterized by depigmented white patches surrounded by a normal or a hyperpigmented border that is called as a distinct border. It should have a distinct border. It's characterized by depigmented white patches. As we all of us know, it's a layman definition of vitiligo. It's a white patches characterized by distinct borders. And it's actually what happens in it, it is selective loss of the melanocytes, functional melanocytes, there's a loss of functional melanocytes, which in turn leads to pigment dilution, and thereafter the affected areas of the skin becomes white or depigmented, what we call the depigmented patches. Now, is leukoderma, what we call in the layman's language, they call it leukoderma. So, but leukoderma is, as we all know, it is a broader term. It's not vitiligo. Vitiligo has a idiopathic etiology is there, but leukoderma is a broader term. That is, all the depigmented patches come under leukoderma. But vitiligo is one of the leukodermal patches, but it is not leukoderma. Okay, there are other causes also, that like from chemicals also, from sunburn also, from injuries also, from inflammation, inflammatory skin disease also, we can get this white patches. So, and we'll be astonished to know that it was in the 2nd century AD that Roman physician Celsus first used the term vitiligo in the 2nd century AD. But it is quite interesting to note that the Rig Veda, that is around 6000 BC or earlier, it named leukoderma as kilas, meaning a white spotted deer. There is mentioned in our Rig Veda, in our Vedic that is mythology, we'll be finding that it is mentioned as kilas, which is means a white spotted deer, and it has been termed there. And because of this, I think there is a much myths, there is myths and facts about this vitiligo, where we'll find many of the myths are there because of this, that leukodermas is mentioned at kilas. So many of us, and that still continued. So many people thought vitiligo as that's leukoderma also, and as a other that's contagious disease also. So they have generalized this leukoderma, that is vitiligo also. So it is a most common chronic depigmentation disorder where the selective loss of functional melanocytes, as I've already told, resulting in typically there's a non-scaly chalky white macules are there. It's a macule as defined by the dermatological by dermatologists, and because of the loss of melanocytes, there's a typical non-scaly chalky white macules we get. This is called as vitiligo. Coming to the epidemiology. So epidemiology, it's the estimated prevalence of around 0.5 to 2% population worldwide in both adults and children. We get this prevalence. There is a prevalence of 0.5 to 2% population as per the recent incidence and prevalence we get, and it affects people of all skin types, irrespective of the race, color, whatever the skin types it may be, it affects people of all skin types. But still, there is a big geographical differences are there. If we go to various parts of the world, we'll find large geographical differences because of this vitiligo patches. Somewhere we get more number of cases, and somewhere we get very less number of cases. Somewhere we find absent of these cases, there is no case of this leukoderma or white patches. Because why such a difference is there? When we talk that it affects to all the skin types, and it can happen to both adults and children. It can to both male and females. And why such geographical differences? For example, there are many studies. One of such studies, as for example, in China, in a certain province, it was marked that it reported a prevalence of as low as 0.09%. Whereas in India, many regions have there, which has a rate as high as 8.8%. It's a very high rate, 8.8%. So as for example, Gujarat. If you go to Gujarat, if there was many studies, there were also studies there that it showed the rates more than 8%. The rate was more than 8%. So what was the reason for this disparity? So it might be that some provinces that there is this high value could be due to inclusion of cases with chemical and toxic depigmentation. It was found that it may be due to some certain chemical and toxic depigmentation, the reporting may be high, or else the disparity may be due to higher reporting of data in place where certain that is social and this religious stigma. There's cultural and social stigma are very common in those places, or where lesions are more evident as in dark-skinned people, because it's obvious that in dark-skinned people the lesions are more evident. So in those places might be the cases are, because they are reporting more, so might be the cases are highly evident over there. Okay. Now coming to the males and females, also the sexual discrimination. Males and females, if you consider in everyone's clinic or in our practice, we'll find more commonly the females are, of course, today everyone is coming to us, but days back, if we go past 10 years back, if I go 10 years back, I found that females are the they seek consultation more frequently than the males. It might be because of this, as I told, it's a cosmetic problem. with this disfigurement. That's a cosmetic disfigurement. So girl child, the parents come with their girl child that they have to, what will happen to this child if these spots are there? No one will marry her. And even in married girls also, in married women also, sometimes what we were seeing that if they have the white spots, the husband and her in-laws, they won't accept her. They are kicking out of this house even after she's married for 10 years or 20 years, 10 to 15 years. If she gets the spots, and if she had got the spots earlier also, and if it was seen after the marriage, they were not accepting her because of these spots. So this social stigma and cultural stigma still prevails in many parts of India, and because of which girls and women are they're facing lots of problems because of this. So more fun. It is not that it's more in females or more in males. It's more males and females are equally affected. Although women and girls seek consultation more frequently. Okay, and it occurs at all ages. But most commonly we find young people are affected. It is 10 to 30 years of age people are there. Though a 10-year boy or 10-year girl develops a disease, develops this clinical condition, a single patch, and gradually this up to from when she's 30 to 40 years or 50 years of age, gradually these spots have now become generalized, and therein the single spot had now gradually developed into many spots or generalized spots. Okay. Then coming to the and more one simple one another thing. Although it is a painful condition, whereas vitiligo, if you know, it's a very painful condition because, as always it is told, it's a cosmetic problem. So it is not a painful condition, but there's a lot of pain in a mind. There's a lot of pain in the mind. Though it's physically we are not facing the pain, though the physical, the person or the individual doesn't have the pain physically, but mentally, mental agony, mental depression, and lot of this social stigma. Because of this social stigma, there's a psychological distress. Okay, there's a because of these surrounding factors, there's and secondly, there's a cosmetic disfigurement. That what this patch has become, if that occurs in the face, even then that's a major disfigurement, and no one will look at her. That spoils the beauty of the child. That spoils the beauty of the girl or the boy. And what happens? The condition tends to affect the quality of life of the patient also. Obviously the person or the boy or the girl or the man, what happens? There's a reduction in it affects the quality of life of the patient, and the patient eventually what happens? They often suffer from psychological distress. Because of this, they suffer from psychological distress, and there is a low social or self-esteem. Okay, there's a low self-esteem. They don't have the confidence to face the people. They don't have the confidence to talk with the people. They don't mix with the people. So there's a certain type of, then this eventually leads to depression. So at times they are subjected to social neglect. Sometimes they have been neglected because of this discrimination made to them because of the spots that it is contagious, and some people neglect them, don't invite them to society. They don't invite them to some cultural social programs over there. So they feel demoralized over there. There's a psychological distress, and gradually this leads them to isolate from the society. So this is a major impact which is having on this because of this disfigurement or cosmetic problem. Coming to etiology. As everyone knows, till now also, of course, nowadays in the recent studies, we have been a little bit clear about the etiology, that it's okay. Now it has come that autoimmune, it has been named as autoimmune. And okay, autoimmune factors are highly, more majorly responsible for this melanocytic death. But till now, many theories have been built, that is neural theories, then autoimmune theories, genetic factors are responsible. Then hormonal theories also came to them, and then some cytotoxic theories. Every theories have come to. Then some nutritional defects may be there. That is improper copper metabolism. Many theories have led to to these days. And now, as per recent studies, if we come to the recent studies, we get that okay, this autoimmune. That is, as a recent progress has been made in our understanding of the pathogenesis of vitiligo, and it is now clearly classified as autoimmune disease associated with genetic, environmental, and metabolic conditions. Okay, factors together with metabolic oxidative, there is oxidative stress and cell detachment abnormalities occurs. So what I have shown here, genetic defects is there, autoimmune factors, nervous system or neural defects are there, and this oxidative stress, trauma, stress, physical stress also there, that to the melanocytes, what happens to the functional melanocytes, all of these factors attack. And when these factors attack, they lead to autoimmune defect and then to melanocytic death, which leads to white spots or vitiligo. So because it is not our mode of the case to, if we are not experts of this etiopathogenesis or this particular conditions, we are dealing with the treatment path and homeopathy. So we won't be going in depth to this, neither can I explain in depth to this etiopathogenesis, but however, whatever I have understood of this, but despite its high prevalence, its etiopathogenesis is complex and enigmatic. Till now also we haven't arrived at a certain conclusion. We are getting nearer and nearer, but still it is very complex pathogenesis. And currently available evidence supports the occurrence of an autoimmune phenomenon with an underlying genetic predisposition, as I've already told, environmental triggering factors, genetic factors, immune response, dysregulations, all this mix up and they promote this autoimmune imbalance. Okay. And this can be triggered by stress to the melanin forming pigment for producing cells, that is the melanocytes. There is a stress to the melanocytes leading to this melanocytic death and resulting in vitiligo. So what are these triggers? What are the stress factors or what are these triggers? That might be sunburn, there might be mechanical trauma, there might be some chemical responses, exposures also. And all these things, environmental, genetic and immune response, all these ultimately together, they cause an autoimmune response that targets melanocytes, driving progressive skin depigmentation. The other things, what I've already told, oxidative stress, endoplasmic reticulum stress, and autoimmunity. In autoimmunity, many things are there. There is anti-melanocyte antibodies, even the interleukin cells and the CD4 and CD8 cells. They all are cytokines, anti-inflammatory cytokines, decreased T cells, autoreactive T cells, everything there, interferon cells, they are also gamma cells, they are also, everything is involved in this, leading to autoimmune response. Then coming to the most important part for our treatment also, for our case taking, there's the impact. There's the most important part, it's the impact of vitiligo. As I've already told, I've already discussed in the first former part also. That is, what is the impact? It's a gradual loss of melanin, okay, resulting in depigmentation, as it is physically seen obviously. And the cosmetic problem is psychological devastating impact. Why devastating impact? Because there's a burden on the daily life. And this burden, gradually it leads to mental distress, psychological distress also there, and then it leads to psychological disorders. This psychological distress, it leads to psychiatric, it becomes psychiatric disorders. In a span of time, a span of years, it becomes psychiatric disorders. In 16 to 35% of patients, you can imagine, it's 16 to 35% of patients go through this psychiatric disorders because of this social stigma, leading to this low self-esteem, poor body image, depression is there, sleep disturbances are there, suicidal thoughts are there. Many patients come to me, even if I tell that is within this 17 to 18 years of that is 15 to 16 years of my clinical practice, I have seen a lot of patients, and with every, I have to spend a major time with them for the counseling purpose. That what it is, I have to tell them, I have to counsel them, their family members, their attendants, what it is, I have to counsel them. So that's the major part, because they are going through a very critical condition. In the there is psychiatric disorders. Even I have seen patients, they have committed suicides because of this disfigurement. Okay, so it is a very important part which many of us don't take care of, or else we only take these physical conditions or basing upon which people prescribe our medicines. And obviously, we know that it doesn't cause any organic harm. No harm is there. No, because of which we can our treatment part is. I think our treatment part has a positive effect because of this. That there is no organic harm, and it takes a lot of time for the treatment. So these are the what I have told. Misinformation, the most important, one of the most important part is that misinformation and lack of information. What is this misinformation and lack of information? These are some of the myths. If we go to some myths and facts on vitiligo, you'll find that the myths for vitiligo, there are many myths that people tell that it is contagious. As I've told, because it dates back to the Rig Vedas, where in Ayurveda also it has been mentioned 6000 in BC that it's kilas. That is the vitiligo. So everyone think of it as what is its kilas? It means a kushrog. It has been mentioned about the kushrog, and everyone thinks in the villages. If you go to the villages, even in the cities, also even in the educated mass, also we will find that this misinformation, misconception is there. That these are the one form of leprosy disorder or leprosy. That is, they tell us the speakers that it's something like kushrog. That how should what kind of spots are there? It's maybe kushrog. It is contagious. Okay, and people make them to sleep aside, not touching them. They are not. They won't be touching them. In-laws, if she's a lady, then they'll be avoiding her. They'll be making her to go back to her mother's house. And after treatment, let she come back. And no one shares food with her. So these misconceptions, my myths are everything over there. Some tell us that, ma'am, okay, some patients come to my clinic. They tell us that, ma'am, is it because of some food disorders? They have a misconception or myths that is it is because of some food. That is, if you take fish, you take milk, this happens. So we have to clear this myths and aware them with the facts that nothing vitiligo has nothing to do with this food. There's food facts that if you take fish and milk, this spots will occur, or it is contagious. If you are sleeping with her, if you are having food with her, if you are sharing food with her, this will be by contact also this will occur. So these are the myths. And this, because of this inadequate, misinformation also, there is a psychological or psychosocial distress in the patients or the persons. Okay, so and stigma and discrimination is also there because of this. Most important is in Indian society, marriage difficulty. There's a marriage difficulty, and if it is in the boys, they discriminate that okay, for them also the same problem that I won't be married. I'll have a marriage discrimination, a marriage problem, and the most important question they often ask if they are unmarried. The most important question what they ask is, ma'am, if I get the treatment, I have this vitiligo, will it be carried to my offspring or my child? Will my daughter or son will also have this? So these are the important questions regarding this vitiligo and the mental health concerns. What we have done because of this so low self-esteem, depressions, and everything, this distress. So all these things lead to psychosocial distress in vitiligo. Coming to the classification, this is the age-old classification. What we know, vitiligo is again classified to two types, that is generalized and localized. In generalized, again, we have classification as acrofacial, vulgaris, and universal. And localized, we have the focal, mucosal, and the segmental. But recent classification have classified it into two types, that is segmental and non-segmental. Excuse me. If we go to this, in 2011, an international consensus classified vitiligo into two major forms. It is non-segmental, it is NSV, and segmental, it is SV. The term vitiligo was used to designate all forms of NSV. So what we are seeing, most commonly what we see, they are the NSVs. It is a non-segmental vitiligo, which includes acrofacial, mucosal, generalized, universal, mixed, and rare variants. Actually, what happens here, in the non-segmental, initially they are segmental, Initially, that tends or pretends to be segmental, that is in one single spot will be there. And later, as I have already discussed, in later parts of the years or in as the gradually, because it has a very slow process. So what happens later, it develops into universal or generalized patches. So that's why we call it as a mixed type. What we normally see in our daily practice, it's a mixed type. This is mostly what is a segmental, non-segmental vitiligo, mixed segmental vitiligo, and mixed vitiligo. That is non-segmental is the symmetric macules, that is there may be bilateral or the bifocal also, and they are limited to face, hands, feet, and genitals involving either limited or extensive body surface area. In the course of time, it may also involve whole body or generalized. It may become generalized. Segmental, as we all know, it is one or two multiple segments. In particular segments will be having as for example, if it has in the right side of patches is on the right side, all the patches will be on the right side, or on the left side, if it has all the patches will be on the left side, then it will call it as a segmental. Or else supposing in the lower segment of the body, we have the spots in the lower segment of the body, we'll also call that as a segmental vitiligo, or in the upper segment only, then we'll call it as segmental vitiligo. Okay. It may be unilateral or bilateral. Then coming to the mixed vitiligo, what I told, initially exhibits symptoms of segmental vitiligo, as I told, affecting 20% of the body surface area, which eventually develops into non-segmental vitiligo after a period of 6 months or 1 year, whatever the period it takes, it will develop. Gradually, it develops into non-segmental vitiligo. So that is called as a mixed vitiligo. Sites. So any part can be affected. Predilection to areas with repeated friction and trauma. Dorsal aspect of hands and feet, elbows, knees, these are the most common sites where we get this vitiligo or white patches. Then course, if we come to the course, that is onset is mostly, as I have told, it is below 20 years. Slowly progressive, usually it's usually slowly progressive, it's a very gradual progress is there. And the segmental vitiligo is very stable, but whereas this it progresses slowly, but in segmental vitiligo, it will more commonly you'll find that there is stable. Okay, and the spontaneous pigmentation in 10 to 20% will be there. That is self-limiting in 10 to 20% of cases. Automatically, there will be repigmentation without any treatment. Then there is acrofacial vitiligo. It is resistant to treatment. There is no effect of treatment on this acrofacial vitiligo. Coming to these prognostic factors, what prognosis we have? As far as I have also seen these many years, I have seen these cases. I also saw this long-standing disease. Long-standing disease, leukotrichia. Leukotrichia means in which the hair is also discolored. There is a white discoloration of the hair along with the patches. Acrofacial lesions and resistant areas. Resistant areas means which areas? Which are, that is, we call it as where we don't get the sunlight or the unexposed parts of our body. Okay, those patches, those areas, they will have a poor prognosis. If we have on the muscular parts, because I have seen in the face or on the arms also, and we have it in the flexor aspect, that will be cured, that will be treated easily. Those patches will go off easily by the treatment, whereas the patches on the extensor aspect and on the bones and joints and the lips and all the mucous membranes patches, they will have a poor prognosis rather than the muscular parts. Coming to the associations, what other associations? This is the most important part, that of course it does not cause any harm, it does not cause any organic harm or pain to the body, but it is associated with these endocrine disorders. Many diseases associated with, because that if you have diabetes mellitus, if you have a pernicious anemia, if you have Addison's disease, if you have hyperparathyroidism, hypothyroidism, or hyperthyroidism, all this they are more prone to get this vitiligo. Okay. So these are we should always rule out this particular diseases, clinical conditions while dealing with the case of vitiligo. Coming to treatment aspect. So standard care treatment, we have this of course they say it is difficult to treat. Early treatment options include exposure to intense ultraviolet light such as narrow beam UVB rays, ultraviolet B therapy, photosensitizers taken by mouth such as trimethylsorelin plus UVA. It is the most common treatment what we have got. It is sorelin treatment. Topicals, they use the corticosteroid therapy. They give corticosteroid creams which have a very weak effect. Immunosuppressants such as this pimecrolimus, who is there. Then repigmenting agents such as methoxyline, oxorelin, all these are there. Then excimer lasers, systemic steroids, and then lastly there is the surgery also. But all the treatments are a failure because they lifelong there is a scope of recurrence. There is a recurrence of this after all these treatments also. There is a recurrence. So they don't have a positive treatment effect. Now coming to the treating vitiligo effects. So as I have told, it has a lot of psychological, or it causes a psychological distress, psychosocial distress is there. So mostly our aim is to treat this psychological aspect. So let us first treat the psychological aspect or psychosocial aspect of this disease to get entry into this particular clinical condition. What to do? Many of the studies now, they have started incorporating the psychosocial interventions and counseling in the treatment of vitiligo. This counseling, it has a major impact. It has a major impact. Many of my friends over this in forum might be knowing this, whoever will be treating this condition. They all might be dealing with this problems, and they all might be doing this part. That's the major part is counseling. It is a major part we have to do in this particular clinical condition, counseling. It has a very positive effect. So first it should have a confidence. The patient should gain confidence that, okay, this is not any disease. It can happen to anyone. It is not he who has got this disease, or it is not nothing to do with the social stigma. So we have to counsel. This is the most important part we have to do with the patients. This counseling has a very positive effect, whatever treatment we give to the patient, but we should do this counseling, which will carry a major time also to make him understand, because he has so many years he has suffered from this disease. So he has to confident enough, he has to gain a confidence upon us that, okay, I have reached the right person now, and okay, if I have a treatment or not a treatment, but this is not going to hamper me in any way. He should be free mentally. That is the main thing. That is the most important thing what we have to do here. Improving the QOL, that is quality of life of vitiligo patients. What we have learned that this particular clinical condition, it reduces or has an effect on the quality of life of vitiligo patients. They have because of the psychological distress, they do go into depression. So taking out of these patients out of depression for these patients, that is a great achievement. So we have to improve the quality of life of vitiligo patients, and that will require knowledge about the conditions and social acceptance. We have to go in deep into the patient, about his conditions, about his social and cultural relations. Okay. It is a very long process and it needs time, always involves sunlight or ultraviolet light, as I've told, and the inner parts are the private parts. Needs time for the treatment, so they have a poor prognosis. So coming to our treatment part, but we should have apart from this counseling, we should have a proper case taking and homeopathic simillimum plus psychological counseling. These two, if we combine these two parts, then we can achieve a good treatment. Next, coming to our study. So it was in CCRA, Central Council Research in Homeopathy. We did a study on this. That is in 4 institutes and units of India. It is a study from 2005 to September 2010. We had this study from which I'll be presenting this case, and to identify the usefulness of individualized homeopathic medicines in management of vitiligo. It was our objective. In which we had these are the exclusion criteria: systemic disease, pernicious anemia, alopecia, lichen planus, psoriasis, all these hydration diseases, whatever we have discussed around that it can have. Those things we have completely excluded all these things, and we have pure cases of vitiligo we have taken. The case taking, it was recorded in a proforma, especially evolved proforma was used for this case taking, and all the complaints of starting from the evolution, everything was recorded in this case taking. Analysis and evaluation, miasmatic diagnosis and totality of symptoms was done. Selection of medicine was done with complete repertory in consultation with Materia Medica. We have developed this VSSS, that is Vitiligo Symptom Score Sheet. This was to assess the severity of vitiligo. This was to measure the severity of vitiligo. We had made prepared this vitiligo scoring sheet, which was approved by the Scientific Advisory Committee of the Council, and it is used to get a quantitative assessment of improvement at each visit. Which in each visit, each monthly visit, we used to have this VSSS, and we are depending upon this, basing upon this, we had to assess the improvement. Severity of vitiligo was categorized on the basis of baseline scores as mild, moderate, and severe. This was the particular VSSS sheet which we used to have at that particular time. This was the type site of lesion. It was the patches was classified according to site of lesion, number of patches, hair in patch, margins of patch, color of patch, repigmentation is there not. What type of repigmentation, everything this is used was to be the sheet basing upon which we assess the improvement. Then the resolution, collective effort to drive extensive global vitiligo awareness to help ease the psychological effects of vitiligo, to help alleviate the misunderstanding of the public, neglect and underestimation of both the public and medical community, improve the quality of life, all this. Now coming to major part is the case report. This is the particular case. He was a 26-year-old male reported with a complaint of depigmented white spots on face and neck since 2 years. He was having this since 2 years, and on the face, as you could see, evident from the photograph also, picture also, he had these patches around the eyes, around the neck. He had these patches. You can see in the lips also. He had these patches, and he was also having the pain in left hypochondrium since 20 days, which was after foot. Color of the spots as pinkish white, and he developed his complaints 2 years back as a depigmented spot on the forehead. He had a small spot on the forehead which disappeared on its own, followed by similar spots on neck and chest, and finally on the face. Okay, and it started as a small eruption followed by itching and then turning white. Every time an eruption occurs, it had started itching, and then later on it turned white with a white macule with distinct borders. Coming to the life space investigation, there's a childhood uneventful. He had studied up to standard 9 and then discontinued due to lack of interest in studies, then started working from the age of 15 years, finally working in a cloth shop. And the past history, nothing such significant. He had a severe diarrhea and vomiting at 19 years of age, and for which he took allopathic treatment and got cured. Family history, nothing significant is there, no such significant history of vitiligo in any, as told by him. The physical generals, he was reduced appetite since 1 year, thirst was moderate, desires for sweets mostly, and he had an unsatisfactory bowel movement. Profuse sweating was there from the soles, especially from the soles in all the seasons. There was the sleep was refreshing, but he used to lie on the right side. And there is the intolerance to hot weather, that's he was a hot patient. No mental journals, there's nothing significant I could get at that particular time. So taking the totality, I got this, I framed this totality, all the symptoms, evaluating the symptoms, hot patient, desire for sweets, reduced appetite, unsatisfactory stool, profuse perspiration from soles, urine yellow, sleeps on right side, pain in left hypochondrium, that was a particular symptom he had. And the baseline score was 14 at that particular time, basing upon the score sheet. This was the repertorization which I have done, which I did at that time in the Homeopathy. It's complete repertory. And you could see that sulfur had the highest scoring medicine, then coming to followed by Lipo, arsenic, nitric acid, aurum, and all these things. So from the repertorial analysis, as I have told, I have selected sulfur basing upon the characteristic generals. And the first prescription I made him sulfur 31 dose plus SL for 1 month, because we had to follow for 1 month. After 1 month, so I would prescribing sulfur 31 dose plus SL. Then the next follow-ups which I got, there was no change. Again, repeated the prescription sulfur. Then in this next for 2 months, again I got, there was little depigmentation, dark repigmentation was there, appearing on the spots below the eyes, and the baseline score was reduced to 9 from 14. So I prescribed him SL. This was the next. In the month of October he came. Then also the spots were improving. They started improving, and the baseline score again reduced to 8. And medicine I prescribed again SL for the next 1 month. Next, in the next month of November, there was improvement, but no new spots were there, and dark pigmentation of the white spots more than before. Itching all over body with eruptions, but there was itching all over the body with eruptions. So again, I have to prescribe a dose of sulfur, followed by SL. For the next 2 months, again he was having improvement. So, and the baseline score was static at 8, but still prescribed him SL because the improvement was going on. And again in February also I prescribed him SL, and in it went on. Now the spots went on improving. I have to only continue with the SL, and ultimately in October 2009 there was the still improvement was going on, and the patient used to come at 1 or 2 months duration, sometimes 2 months. So I used to follow up him. I used to call him up at 1 month, but because of his work schedule, he used to come at sometimes 1.5 months or 2 months duration. He used to come to me, and still there was improvement. So I prescribed him SL. Okay, so these are the pictures. If you can see those pictures, this is a picture of first picture is of April 2008, and the second picture of the July 2008, as evident from the follow-ups also. We could see those repigmented patches over there in the eyes. If you can see these patches, which were not in the first picture. In the second picture, in this left eye, you could see these the repigmented patches over there. In the neck also, see some spots are there, independent spots are there. These are the next pictures. You could see in the third picture, there is August picture, that see the major repigmentation has occurred under the eyes, and in this neck portion also there is a repigmentation. This is from sulfur only. It's to be honest, I have really prescribed him sulfur 31 dose, and this is a case till now also. I appreciate this case, very nice case, a pure case of vitiligo. And these are the pictures. See, it is of December 2008, wherein mostly the patches around the eyes have been covered of this patient, and the neck portion. You can also see the neck and the chest portion. You can see the spots have come, repigmented spots have also appeared over there. See, and these are the spots of February. These are this is the spot in also February in the neck and the face. You can see that the improvement. The improvement is evident from these pictures, and the date is also there, because we used to take at that time the pictures with papers also written, the date written on it. Excuse me. And these are the ultimate pictures, final pictures which I got from the patient. That is a 15/10/09. That is October. In the month of October, you can see the face. It is crystal clear, except from the lips, which he has the spots. Otherwise, all the face cell spots have gone. Okay. After that, also I have followed the patient over phone, and also he has came to meet me several times, and he had this. They did not recur. These spots till now didn't recur, and this spot, this neck portion, you can see such an improvement. You can see the first picture. If I go back to the first picture, you can see the neck portion over there. You see the neck over here. You can see such a what was that? They see this first picture's neck, and if you go to the last that is October's picture, you can see the neck area, how much the repigmentation has been done, and it's only a single medicine, sulfur, was given to this patient, nothing else. So this was a more improvement case, and more improved cases also are there. These were the recent studies which I had done, and in this you can see the patient. This was having the spot under the chin, that is just above the neck, under the chin. He had this spot. Last spot was there. This was during the treatment. It was the repigmentation had continued, and this was the final picture of his where the complete repigmentation was there. This is again a case. The treatment is going on. before and during. This is see the neck portion, the chest, neck and chest portion. Such white spots were there, and now it has become like this. The spots have come repigmented. The repigmentation has gradually appeared in this case. This was also by sulfur. This is also a case of sulfur. In my treatment, I found sulfur as the most common indications. This was a case of arsenic amalgam in which he had the spots in the arms. You can see the spots in the arms. I couldn't get the pictures actually in a short notice. I had all these pictures of his. He had also, this was a picture, this was a case of segmental vitiligo. This is the only case I have got of the segmental vitiligo, when he had the spots in the right side face, right side neck, right side arms. These two places he has got this patches, and now the neck patches have been cleared off, and arms also you can see it has also been cleared. This is also a case of arsenic amalgam, wherein he has got in the forearm these patches because he had a lot of hairs on it. It couldn't be, but you can see the white color of these patches, and here the natural color of the skin has also appeared over here. This is a case. This was a case of actually phosphorus. When in the back there were spots and eruptions also there with itching. There are many spots of the white spots, and this was been cleared off here in the next picture. This is a recent case. I'm treating this case till now also. So this is a case of vitiligo. We can be evident from the face itself. You can see around the eyes, on the forehead, and the face, everywhere she has got these patches. On the neck also she has patches, and on the back also she had. And I collected this photo for you. They see only so very small, minute spots are there on the forehead now, and it has been cleared off. This is the after treatment, and now also she is continuing treatment with me. This patient, you can the repigmentation is quite evident from these pictures. So this is all I had to present for this vitiligo. So as I am to tell that okay, that's keep calm. It's vitiligo and it's not contagious. That's what I tell, and that this message only we have to spread in the public. That's the keep. It's only vitiligo. It's just a white patch. It's not contagious. It can happen to anyone. Irrespective of any sex, any race, or any color, it can happen. So we need not to worry. We should not make it a social or a psychosocial distress or psychological distress. It should not create, or we should not have any. We should not have any depression about that. If some student, even some students are there, we have vitiligo, and they're good in studies. Their parents tell that now is not here, she is not going to school because of this. Then I used to counsel them that, see, this is one part of your body. But your mind, your intellect, that no one has taken, no one has disturbed it. You can study, you just concentrate on your study and make your life, or you get into such high level that everyone forgets it. No one will have a notice on this. It's just a point of time that someone comments on this. But why do you think you should not bother what others think about it? We should never think what others think about us. We should always listen to our mind, what we are. We won't change whatever the color of our body. It's just a cosmetic aspect. In one or other day, we have to. Okay. So thank you very much for this giving me this chance. That's the thing we have to do.
Yeah, we have only 6 minutes remaining for our question and answer session. So those who wish to ask questions, please go to the participants list and raise your hands to ask our question and answer sections. Dr. Beatrice from Germany. Dr. Beatrice, you can ask your question very shortly.
Okay, thank you very much. Very shortly. Point one, just to be sure, how often did you give sulfur? Every month or every day? I did not get that right.
No,
and rubum, what is about rubum? Okay, just to be there.
Thank you very much for this question. Actually, as I told, sulfur 31 dose, only one single dose I used to give, yeah, and followed by SL for 1 month. Only sulfur 31 single dose only one day I used to give sulfur, and the other days of the month, 30 days of the month, I used to prescribe.
Okay.
You used to prescribe what? Rubrum or what?
Yes.
No,
I
madam,
used-
she only gave one dose, single dose per
Yes.
month. Okay.
Yes.
Okay.
Yes.
That's great. And the second point, I just one second. It was so impressive. You were talking about the psychological problems. This vitiligo is decreasing, and for me, it's interesting from cultural differences here in Germany. Of course, we don't see if a patient has a vitiligo, you don't see it so much because our skin is more white.
Yes.
Okay,
Yes.
but we have other problems with pimples, with neurodermatitis, with many things. Okay.
Yes.
But I
Yes.
just can tell you that, of course, people are not happy to have this, but on the social way, we don't have problems. I saw nice girls with strong eczema in the face, and the boyfriend was perfectly fine. Okay.
Yes.
So, yes, that's a big issue. And yeah, thank you very much for explaining so well.
So what's the question? So yeah.
I feel pity for these people. Yes.
Yes. Thank you.
Okay.
That is only a
much.
statement.
Thank you very much.
Yeah.
That's only a statement from Dr. Beatrice, who is also dealing with the dermatologist cases, because
Yeah.
she is a
Yes.
dermatologist converted into homeopathy doctor from Germany.
Okay. That's
Okay.
very nice to me.
Yeah.
Yes.
Now
Very
I
nice
go
to hear
to
your
now I
comments
go
also.
to now I go to Hanan Nasar. Hanan Nasar, we have very short time. Please come in with your question very shortly. Yeah.
Yes, thank you, ma'am. Ma'am, my question is, what is the percentage of curability in these cases?
Yes,
Cura-
as I told, yes, it's a very, as we told, this is a very important question also, but the percentage of cure, see, it has a very less percentage of cure. I won't tell it has 100% of cure, but in my clinic, whichever patients I have got, there is 30 to 40% cure. It's not even 50%, but 30 to 40%. And if
Okay.
Okay, ma'am,
Thank
I
you.
have a
get a
personal
good case,
experience.
if
to
you
share.
do a good case
Ma'am,
taking, yes. Yes, of
ma'am, I
course.
have a doubt, one more doubt. My son is having this vitiligo. That's why I'm asking. He was
Okay.
having first itchy all over the body, but now no itching, but only milky white patches on the face and legs mostly.
Mhm, mhm.
We had taken Unani treatment from Hyderabad at early time, but
Okay.
it was discontinued because of the herbal medicine the child is not taking.
Mhm.
And now I started our homeopathic treatment, but pigmentation is not that much as we expected, and still it is progressing. Because earlier he had on face, it was very much got cured by Unani treatment, but now
Okay.
again that it is again reappearing. So what is what may be the reason? Because it is again
See.
reappearing.
Yes, since how many years he has got this?
6 years, ma'am.
6 years is a very long time, and he has taken allopathic treatment also.
No, initially only because when we couldn't identify what it was.
Doctor, we
then
have
only
lack
one
of
month.
time. Dr. Hanan Nasar, I appreciate you directly contact Dr. Lipi and you can discuss it in person so
Of
that
course.
Okay,
Sure,
because
sure.
we have lack
One,
of time. We have
okay, for
only
external
1 minute.
application, do you recommend external application, ma'am?
No, I don't recommend external applications.
Okay.
I don't
Now
recommend.
now I go to Muhammad Saidan from Jordan, please.
Thank you.
One 30-second question and 30-second answer, please.
Okay. Thank you. Audible?
Yeah, audible, please.
Oh, thank you. In the first case that been discussed, the mom has introduced that the patient has hypochondriac pain after food intake.
Yeah.
Yeah, that means the patient has indigestion or something wrong in his gastrointestinal system. And accordingly, we should be able to diagnose and treat the gastrointestinal system. It might be the root cause for the vitiligo. What do you see? What do you see about those patients? Do they come with gastrointestinal disturbances?
Not all the patients come with gastrointestinal disturbances. Some of the patients come with gastrointestinal disturbances, but not all the cases. Most of the cases, I don't think they come with gastrointestinal disturbances. But vitiligo is mostly, if I tell. Yeah.
The idea, it might be gastrointestinal, but it is hidden.
There are many others.
It is beyond their appreciation. We should be able to check their gastrointestinal systems in order to treat vitiligo. Believe me.
Yes,
Thank
yes,
you.
sure.
Thank
Yes,
you,
of course, we should treat.
Thank you, Dr. Saidan. So now it is time to wind up today's session, as we have to proceed to the next section in our local language, and we have some very important dignitaries appearing in our session today. So thank you to all those who asked questions, and
thank you very much, sir.
Yeah, thank you all, and also thank you, Dr. Lipi Pushpa the Beta from UP. Are you from UP?
Yes, I am from UP Lucknow.
Okay. Thank you, and see you again in our platform. We wish to have you come back again to our,
sure, sir. Thank you very much.
Forum with another presentation. Whatever you do, we wish to listen to you. So thank you very much, and thank you all the participants from different parts of the world who joined us. Now I hand over our session to the next forum, next session in Malayalam, in our local language. Over to the next session. Before that, I wish to have one more announcement. We are reaching 365 days of our daily Zoom meetings, and we are celebrating, and we are the 365 days on the 31st of August, but we are starting our celebrations from tomorrow onwards, and we will be having almost 12 hours program tomorrow, and we will start our session at 9 a.m. tomorrow, since one of our important political leader who will be appearing in our platform will be coming early. So we will be starting at 9 a.m. Indian time. So with this information, I wind up today's English session, international session, and go to our local Malayalam session. Thank you all. See you again tomorrow, 9 a.m.